you will be moderating this room?
A little bit, yeah. I'm doing the introduction.
Okay. Are you doing like the in-between?
No.
I don't know. I can check with Rico.
Okay. Because I just want to remind you that when we go into question and answer from the audience, we need to speak into a microphone for the question because this meeting is being recorded and webcasted.
Okay.
So if we don't speak into the microphone, the voice won't be recorded and it won't be thrown on the internet. So
Okay.
just a reminder when we go into Q&A.
Okay.
So maybe you could remind people at the welcoming
Okay.
words.
Okay.
Reminders.
The question and answers
Yeah, so question and answer,
are in between.
Even if you're sitting at the table, you need to speak into a
Okay,
wireless
so
microphone.
one of us will, I'll take the
Yeah, a mic
microphone
runner
and
or something,
run
and I
around.
have
And
two
there's
of these.
supposed to be a translation, simultaneous translation.
Oh, j'ai pas de
Non?
traduction en simultané dans la salle ici aujourd'hui.
Okay.
Okay. So we'll do.
Okay.
La réunion est enregistrée, mais elle n'est pas traduite en temps réel.
So we're pretty much
Okay.
translated here. I'm not worried about
Okay.
us.
Okay.
Go. Okay, good morning, everyone. We're going to get started. So if you'll please take your spots. Good morning, everyone. My name is Donna Hillier, and I am a co-leader of the Montreal Cnets support group.
Bonjour, je suis Marianne Risdun, co-animatrice du même groupe de soutien de Montréal avec Donna.
On behalf of Cnets Canada, it's our pleasure to welcome you to today's Hybrid National Net Patient Conference. Just a reminder from the organizers that during the question and answer, you will need to speak into a microphone, which I will bring around to whoever has a question.
Ce sera pour vous, cette conférence, une occasion d'écouter des témoignages de personnes atteintes de tumeurs neuroendocrines, de comprendre ce que c'est, puis comment on le découvre, les divers traitements disponibles, ainsi que les essais cliniques. C'est aussi l'occasion de rencontrer d'autres personnes atteintes et des proches aidants.
I would like to take this opportunity to thank Cnets Canada for hosting these events and for their ongoing efforts in raising awareness, supporting patients and caregivers, and funding research of NET cancer.
Un merci tout particulier à Enrico Mandarino de Cnets Canada pour l'organisation de cette conférence et pour le soutien dans la mise en ligne des liens Zoom pour nos rencontres mensuelles du groupe de soutien de Montréal.
A big thank you to Enrico Mandarino of Cnets Canada for keeping our Montreal support group connected through our Zoom meetings on the first Thursday of every month. And it's so nice to meet a few of you here in person today.
Cette conférence ne serait pas possible sans le soutien financier de compagnies pharmaceutiques. Un grand merci tout particulièrement à Ipsen et Novartis. Merci aussi aux divers donateurs et donatrices, dont plusieurs d'entre vous êtes déjà. Ces dons permettent de financer, entre autres, la recherche.
This conference would not be possible without our sponsors, so thank you to Ipsen and Advanced Accelerator Applications, or AAA, a Novartis company. And now to all of our presenters at our conference, thank you for taking time today to share your expertise, your knowledge, and your experiences. And a particular thank you to Dr. Mercier for organizing the speakers. And I believe our first speaker is Sonia Carey.
Okay.
Oh my goodness. Okay. Well, good morning, everybody. Hello. I want to first start off by saying what a complete honor it is to be here. My name is Sonia. I am from the Toronto area, and I have been a neck cancer patient for going on 10 years now. I'm not sure if anyone remembers, but the last time I had the pleasure of speaking at the Cnets conference was in 2017, just a few months after I actually had underwent a liver transplant. And a lot of time has passed since then, and I'm happy to report that I'm doing well, and I'm even happier that I get the opportunity to share my story with you all today. So my experience with my body hurling warning signs at me goes way back to my childhood. I was experiencing heart palpitations and stomach issues like way back into 5th grade. Because the issues were occasional, they weren't taken very seriously, like not serious enough to do any testing beyond like basic blood work and heart tests, which were, of course, completely normal. So I was labeled an anxious child, and it was just left at that. Fast forward to my teenage years, the symptoms started to get worse. I started experiencing facial flushing, unbearable stomach cramps, and my pulse would just get like erratic out of nowhere. Again, my family doctor, who knew me since I was very little, continued to tell my parents that I had anxiety and I needed to be treated for it with medication and therapy. By the time I graduated high school, my symptoms were rapidly accelerating out of control. Any kind of emotional stress or physical exertion would just send my vital signs into an absolute frenzy. My heart would pound out of my chest, my stomach would hurt, it would become difficult to breathe, my skin, it would turn like bright red, and I would just end up on the ground a lot in public places, which was absolutely mortifying. So after some more visits, my family doctor ordered an MRI of my abdomen, which showed multiple lesions on my liver, but because of my young age, of course, no biopsy was ordered, and the lesions were just determined to be benign cysts. I remember lying on the floor of this clinic, struggling with what I would later find out was carcinoid syndrome, having it blatantly dismissed as a simple anxiety attack. I allowed myself to be convinced that I had a severe anxiety disorder for years because I was so young that the prospect of doctors being capable of human error hadn't yet occurred to me. I didn't know that this could be as remotely serious as cancer. I didn't know that I could seek a second opinion or ask to be referred to a specialist. And above all, I didn't know how much valuable time was being wasted. So at 19, I decided to start college after taking a year off. At the time, my career of interest was social work, but unfortunately, I only made it through about a month of studies before my illness completely took over my life. I was so sick that I was no longer capable of sitting in class. At this point, I realized how much I'd lost in such a rapid amount of time and would continue to lose if someone didn't help me. And that someone ended up having to be me. You know how you're told not to Google your symptoms because the internet's just going to tell you that you have cancer and unnecessarily scare you? Well, I began to wonder if I really did have cancer or some strange disease that was just unknown to the rest of the world. There wasn't much helpful information online at the time that aligned with how I was feeling. I started to think that maybe we just never know. And then I came across an article on carcinoid syndrome, which we all know now as a syndrome that is caused by neuroendocrine tumors when they secrete certain chemicals into your bloodstream. I had no idea how many times I was going to be hearing the word neuroendocrine going forward. So off I went, back to my family doctor. I asked him to order blood and urine tests for this rare cancer I read about on the internet, and so he did. And the numbers were off the charts. And I was referred to a surgeon who scanned me again, this time with a CT, and told me that the so-called cysts on my liver were very likely metastases of what looked like a tumor that they had discovered in my small intestine. One thing that I'll never forget is being told that if it was neuroendocrine tumors, like they were expecting, that there was a very high likelihood of the primary tumor existing since I was 10 years old. So I was biopsied. The biopsy confirmed the suspicions to be accurate, stage 4 neuroendocrine cancer. and it was devastating. When I heard stage 4, I just assumed that that was it. Cancer is cancer, and the idea that somebody can just live well for many years with cancer that has spread to an organ was just a foreign concept to me. Nothing I read online about survival rates was very reassuring, and I was more angry than I was scared. I tried to make an appointment with my family doctor to follow up on the news, but he shut down his practice, so that closure was something I never received. So there I was, 19 years old, in an absolute state of shock, navigating this whole new world from scratch. Cnets actually helped connect my family and me to the valuable information that we needed, and for that I am very, very thankful. It was a super dramatic shift. My life no longer revolved around my education, working, or going out with my friends to our favorite pub on the weekend. All of those things were just suddenly gone. Cancer became my 24/7 occupation, whether I liked it or not. My first surgery was a small bowel resection to remove my primary tumor. I had hoped that the surgery would lessen my symptoms, but the fact that the disease had spread so far into my liver, that was what was making me so sick. I asked if there was any hope of surgical resection like I'd read about for some people, but I was told no. However, my cancer was low grade, and it was mentioned that I could potentially be eligible for a liver transplant at some point in the future. And I remember being really taken aback by this because that's such a major surgery, and I couldn't fathom going through something like that, but I had no idea how much strength was going to be required of me in the coming years. I spent time in so many different hospitals, I don't even remember them all. A lot of tests were done to determine how we were going to proceed with my treatment. I remember being told that a good portion of my liver had been replaced with tumors, which looked like an infinite number of like little watermelon seeds on my scans. It's not really what you want to hear. The tumor board extensively discussed my case, and they decided that they wanted to give me a transarterial embolization to attempt to destroy some of the tumors and stabilize the rest. It's a treatment that's normally just done in one go, but because of how many tumors I had, they actually had to treat like one quadrant at a time over several months. Afterwards, I received some stability, some minor symptom relief. A lot of people in online support groups that I was in told me that there was life with this disease, that you just had to get used to your new normal. But as someone who felt unwell 24 hours a day, I struggled to understand what this meant. I still couldn't leave the house, and whatever time wasn't spent in the ER collecting another admission bracelet was just spent in bed. Over time, I developed what presented as a severe allergic reaction to almost everything I tried to eat until there was nothing left except for like boiled vegetables and rice, which was super boring. I remember I spent the majority of my days just trying to learn more about my illness and discover some way out of the prison that my body had become. I wanted to give up countless times, but I knew there was some reason why I was fighting so hard to live. In October 2016, I was finally given a chance at surgical intervention when I was put on the liver transplant list at UHN in Toronto. The main requirement was for the cancer to have remained stable for at least 1 year with no visible spread beyond my liver. A lot of tests were done to make sure my body was strong enough so that I could have this major surgery, but I was put on a very low priority on the list because my liver continued to function well, even though I was in just terrible physical shape at the time. My family worried that I wouldn't make it if we waited for a call, so I agreed that we could put the word out that I was looking for a living donor. And this was extremely hard for me to do because how do you just ask somebody for a piece of their body? Like, what makes you deserving of having someone go through an operation for you? Well, on January 13th, 2017, I received the call. At this point, I was barely eating anymore. I slept most of my days away. I lost so much weight that I looked like a completely different person, but the hope that I was given at that moment was enough to just send me flying straight out of bed. And that Friday the 13th ended up being the luckiest day of my life. The call that I received was for a living donor, and at first I had no idea who this person was, only that they loved me, an absolute stranger, enough to go through this major procedure so that I might have another chance at life. When I went to the hospital the night before my surgery, I was informed that they would need to scan me to make sure there was no cancer outside my liver, do like a octreotide scan. And it was while I was lying in my hospital bed, just praying desperately that I wasn't just going to be deemed beyond help and sent home, that I received my first message from Pete. It was a quick hello. It was a confirmation that he was going to be heading to the hospital soon, and I'd be meeting him when we were both in recovery. And I just wasn't scared of the unknown anymore at that point. I just knew that wherever I came out on the other side, it was going to be good. So I went into surgery early the next morning. It went very smoothly. I'm not kidding when I say that when I woke up that evening, I was feeling better than I had in years. I remember crying when the meal tray came because I was able to just eat the hospital food with no complications, no symptoms. My heart wasn't beating out of my chest, my skin wasn't rashy, I wasn't in any pain. And so I got up soon after that, and I went for my first walk around the hospital, and it was just so incredible. I was able to walk, I didn't feel sick or like passing out, and then just like a miracle, I saw Pete taking what I believe was his first walk around the hospital as well. We'd never met in person before, but I knew it was him, and I can't really put into words like the range of emotions I felt when we just like locked eyes and limped towards each other with our mobility aids, but I can tell you there's nothing in the world that can compare to the kind of joy that I felt in that moment. Pete had found out about my need for a liver through a news bulletin at my mom's church at the time, and although he'd never met me, he immediately put himself forward to see if he was a match. He saved my life, and he'll always be my hero. So if you're watching this, Pete, I love you very much. Now, the last time I spoke at this conference, the story just ended right there, but there is actually more now, of course. So after undergoing a liver transplant for cancer, the last thing you want to think of is the potential of there being more cancer. And I was very adamant in advocating for myself, which I always have been, because even though I was doing great and my life had returned to pretty much normal, I was still aware of some really mild symptoms that still hadn't totally gone away after my surgery. And so even though all of my tests were normal, I jumped through a bunch of hoops, but I was eventually able to access a gallium PET scan, which to my knowledge is the most sensitive scan that we have to detect neuroendocrine tumors today. And it showed what my doctor called like low volume disease in my like mediastinal region. And it wasn't captured on any other scans. And I remember my first thought being like, what if I'd gotten this scan like before my transplant? Would I have like not been allowed to have my surgery if they saw that? But anyways, starting in November of 2019, almost 3 years after my transplant, I ended up getting PRRT to treat the low-volume disease that was remaining in my body. I completed 3 of the 4 rounds of it. It was actually very easy on me. I still continued to go to school, go about my life, and the response was very favorable. And I've been stable for going on 5 years now. My new liver is still completely healthy and tumor-free. But yeah, one of my main reasons for telling my story now is because I want it to be known that under some circumstances, liver transplantation can be a life-saving treatment for NET cancer patients. I remember before I got mine, so many people in like online support groups were telling me that their doctors had said that liver transplantation should never be an option. So you can imagine how scared I was going into it because this was my last resort. And during my screening, I remember I was informed that it wasn't a very common practice at all, so we didn't have a lot of data to go by. I just kind of had to sign my life away and hold on to hope that it would be successful, and thankfully it was. So you can understand why I'm so vocal about wanting others who may need it to at least have access to that same opportunity. Since my transplant in 2017, I have been able to live a normal life for over 7 years now, And I am so grateful that I've gotten to cry and make mistakes, to see some of the most beautiful places in this world and meet some of the most beautiful people, to fall in love with somebody who wants every part of me, and to learn who I really am and what it means to die with no regrets. Today is actually my 29th birthday, which is a day that I once thought I would never see. And now I'm planning for my future. Just like anybody else, I'm preparing to go back to school in hopes of one day maybe studying medicine. I'm gazing at my big empty couch when I drink my tea in the morning, imagining what my future children watching Blue's Clues on a Saturday might look like. And I'm holding on to hope for continued advancements in net cancer care so that some kid out there won't have to go through what I did. Thank you.
This is the next presenter, Simon Desmarais.
Good morning, bonjour. Mon nom est Simon Desmarais, j'ai 39 ans et je suis un patient atteint d'une tumeur neuroendocrine au pancréas. J'ai été diagnostiqué à l'âge de 33 ans. Depuis près de 3 ans, je suis membre du conseil d'administration de Cnets. J'ai écrit un texte qui présente mon parcours médical. Je pense qu'il y en a plusieurs qui vont trouver des similitudes avec leur propre parcours, notamment sur le temps que ça prend entre tes premières consultations et le véritable diagnostic. Malheureusement, pour la plupart des patients TNE, le diagnostic arrive très tard, dans un stade avancé de la maladie. Ensuite, je vais finir en parlant un peu de Cnets. Le 29 août 2017, j'étais à l'hôpital Sainte-Justine. Pendant que ma femme accouchait de notre second enfant, je vomissais dans les toilettes. Ma femme accouchait et c'est moi qui avais la nausée, qui vomissait et qui était épuisé. En fait, depuis plusieurs années, j'avais des troubles de digestion. J'avais perdu mon énergie, j'avais perdu mon humeur et j'avais perdu ma volonté. Bien sûr, j'avais consulté de nombreux médecins, à la clinique de médecine familiale, à l'urgence et auprès de spécialistes. On m'a répété que le stress était la cause principale de mon état, stress lié à mon travail et à ma situation de jeune parent, et que j'avais simplement un trouble anxieux. J'ai fini par le croire. On m'a prescrit des antidépresseurs et recommandé d'aller consulter un psychologue pour traiter ma situation. D'autres croyaient que j'attrapais simplement tous les virus de la garderie de mes enfants. Même un gastro-entérologue, après avoir exclu la maladie cœliaque, m'avait suggéré de manger plus de fibres, plus d'aliments probiotiques et de mieux gérer mon stress et que tout irait bien. Cependant, 2 semaines avant Noël 2017, mes douleurs à l'abdomen étaient si intenses que j'ai décidé de me rendre aux urgences de l'hôpital le plus proche de chez moi, qui était l'hôpital Sacré-Cœur. Après avoir trouvé une masse aux imageries dont on pensait être un kyste pancréatique, ils ont décidé de m'opérer. Cela s'est avéré être une opération majeure au cours duquel j'ai fait de nombreuses complications. Ils ont enlevé une partie de l'estomac, du pancréas et du côlon. C'était mon premier Noël en tant que papa de 2 enfants. J'ai eu mon congé de l'hôpital le 1er janvier 2018, comme si une nouvelle ère de ma vie commençait. Ce n'est qu'après 5 semaines d'attente que le rapport de pathologie post-opératoire est sorti avec finalement le bon diagnostic, une tumeur neuroendocrine du pancréas. Comme vous le savez, le périmédical de la quasi-totalité des patients TNE commence bien avant le diagnostic. Il s'agit d'une maladie vicieuse et sournoise. Les symptômes sont souvent associés à des maladies banales et à des conditions médicales très communes. Les études disent que dans 50% des cas, il s'écoule plus de 5 ans entre les premiers symptômes et le diagnostic. Dans mon cas, j'estime à 7 ans l'intervalle entre mes premières consultations pour des douleurs à l'épaule et mon rapport de pathologie. Mon premier mauvais diagnostic a été une tendinite à l'épaule. En clinique de médecine familiale, on m'a recommandé de faire de la physiothérapie et ils m'ont même fait une injection de cortisone à l'épaule. En fait, la tumeur irritait mon diaphragme et par l'entremise de mon nerf phrénique me donnait une douleur à l'épaule. Cela fait maintenant plus de 6 ans que j'ai mon diagnostic. J'ai eu ma part de traitement, dont 3 chirurgies par laparotomie, des cycles de chimiothérapie Capten, 2 thermoablations hépatiques et 2 embolisations hépatiques. En raison de mon jeune âge, avant de commencer la chimiothérapie, on m'a suggéré d'aller consulter en clinique de fertilité. Donc, dans la même journée, le matin, j'étais à l'hôpital général juif, où on m'a dit de commencer la chimiothérapie, et l'après-midi, je me rendais à la clinique de fertilité de l'hôpital Sainte-Justine. Vous savez comment c'est fait? Les 2 hôpitaux sont situés à 500 mètres l'une de l'autre sur la même rue. Un sentiment étrange m'envahissait. D'un côté, je commençais la chimiothérapie pour repousser la mort, et de l'autre, je planifiais la suite de ma famille. La bonne nouvelle est que les efforts en clinique de fertilité n'ont pas été faits pour rien. Ma conjointe et moi avons décidé d'avoir un enfant après mon diagnostic, notre 3e. Une décision courageuse pour certains ou insouciante pour d'autres. Le diagnostic du cancer et les traitements qui en découlent sont parmi les événements les plus stressants de la vie d'une personne. Cette tension est d'autant plus exacerbée, comme dans le cas des TNE, lorsqu'on fait face à un cancer peu commun et où les outils, les ressources et même la connaissance du personnel médical sont limités. Il y a rarement de bons moments pour recevoir un tel diagnostic, qu'on soit jeune avec la vie devant, au milieu de sa vie active, ou un retraité qui veut simplement profiter de la vie tranquillement. 3 mois après mon diagnostic, il y a eu la première journée d'éducation patient à Montréal, organisée par Cnets. À cette journée, j'ai rencontré mon ami Daniel, un autre jeune patient. Daniel a su trouver les bons mots pour m'expliquer ce que c'était vivre avec cette maladie. Malheureusement, nos chemins ne se sont pas croisés longtemps, puisqu'il est décédé moins d'1 an après notre rencontre, des suites d'un traitement. Je remercie beaucoup ceux et celles qui ont contribué à l'organisation de la première journée Cnets. Cela a fait une différence dans ma vie et j'en suis persuadé dans celle de nombreux autres patients. Merci Marianne, Miranda, Jackie, Rico et les autres. Dans les premières années de mon diagnostic, j'ai entrepris activement de comprendre ma maladie, son évolution potentielle et les différents traitements. J'ai notamment assisté à des conférences du Neuroendocrine Cancer Awareness Network, NCAN, un organisme américain, et à des conférences médicales à Barcelone de Cnets, l'instance européenne des tumeurs neuroendocrines. Sauf si c'est pour calmer votre anxiété, comme dans mon cas, je vous dirais qu'assister à ce genre d'événement est peu utile pour la plupart des patients d'ici. Juste le fait d'avoir une journée comme aujourd'hui, avec la possibilité d'écouter des conférences de spécialistes et poser des questions n'a aucun prix. Je suis d'avis que mieux comprendre sa maladie et ses traitements permet de diminuer le stress du patient, d'augmenter sa qualité de vie et par le fait même, fort probablement, augmenter sa longévité. Évidemment, les émotions et les pensées peuvent se bousculer dans notre tête lors des consultations et des traitements médicaux, et c'est seulement à la maison qu'on commence à vraiment avoir des questions et à essayer de comprendre. Donc aujourd'hui, c'est l'opportunité de prendre le temps de s'informer dans un contexte différent. J'aimerais aussi adresser un remerciement spécial à tous les professionnels qui dédient une partie ou la totalité de leur carrière au TNE et surtout qui ont accepté de prendre de leur temps pour venir ici aujourd'hui. Merci. Il s'agit de la 4e journée d'éducation patient que Cnets organise au Québec. Nous avons fait 2 événements à la Ville de Québec et c'est le 2e que nous faisons à Montréal. C'est la première fois que nous le faisons en hybride, présentiel et virtuel. Je vois dans la salle certaines personnes qui ont l'habitude de ces événements et je vois aussi des nouveaux visages. J'ai même entendu que certains patients étaient venus de Vancouver spécialement pour notre événement. Cnets organise des rencontres mensuelles entre les patients à travers le Canada. On le fait sur Zoom maintenant, du moins pour le Grand Montréal. Souvent, on ne veut pas trop inquiéter nos proches avec nos conditions. Ces rencontres sont un bon endroit pour venir parler avec des gens qui vivent la même chose que nous. Si vous avez des commentaires ou des suggestions pour les prochains événements, n'hésitez pas à venir le partager, que ce soit avec Donna, Marianne, Miranda, Rico ou moi-même. Merci beaucoup. Je pense qu'on a une première conférence technique, Dr. Soucy.
Okay, hello. Thank you for inviting me. Thank you to the Society and to Dr. Mercier for organizing and inviting me. I'm very honored to be here. So I'm Geneviève Soucy. I'm a pathologist at CHUM. I specialize in gastrointestinal, pancreatic, liver, and biliary tract pathology. And today, my objective is to review with you the current classification of neuroendocrine neoplasm. Pathology seems complicated, but we'll try to explain it so everyone will be able to understand everything, I hope. So I don't know your background, so I'll have a small introduction, and then we'll go to the classification. So neuroendocrine neoplasm originate from neuroendocrine cell systems, so either from organoid cell aggregates, which are glands, or dispersed cell across various organs, which is the diffuse neuroendocrine tissue. So depending on their embryological origin, they are either non-epithelial neuroendocrine cells or epithelial cells. So the non-epithelial cells are associated with the nervous system in various body parts, and the epithelial one are the most widespread. So they are from all the endocrine glands, pituitary glands, thyroid, parathyroid glands, and also in all the diffuse neuroendocrine tissue, in the lung, breast, gastrointestinal tract, pancreas, skin, genitourinary, so everywhere. Regardless of their localization and embryological origin, all of the cells can be the source of neuroendocrine neoplasm. So you have to understand that it's a very diverse, heterogeneous group of neoplasm, and they have different etiologies, manifestation, so morphological and genomic findings, outcomes, etc. So the goal. So historically, there were a lot of terminology, and it was various across all different organs, very confusing for all the physicians and all the workers in the field. And over the years, we tried to unify the terminology and to have like a better classification to be able to better classify patient into the right risk categories and have a more accurate prognosis for them. So today my role is to review with you the current classification, which is the new one, is the 2022 WHO classification. Is that, yes? Do you know a little bit about classification? Okay. So the big taxonomy of this new classification, so the big family is neuroendocrine neoplasms. But then the big taxonomy is like well differentiated and poorly differentiated. So we'll start with that, the differentiation. What does that mean? And then we'll go in more details. So the differentiation is referred to the extent of which the neoplastic cells look like the normal cells. So if it looked like the normal cells, if they look like the normal cells, then it's well differentiated. If it's really like you can tell if it's, you can actually see any features of the neuroendocrine cells in the neoplastic cells, then it's poorly differentiated. Okay, so that's the big part. It's not always easy, but that's the general rule. So in the neuroendocrine tumors, usually you can see the neuroendocrine pathologic features. You can see the different features that are associated with the neuroendocrine lineage. And especially we do some markers in the lab with antibody on the cells. They are specific for neuroendocrine cells, and we do the testing, and we have the neuroendocrine lineage. So we know we have to think about doing the testing, but once we do the testing, we know if it's a well-differentiated cells, we know it expresses the neuroendocrine markers. Okay, so that's one thing. The poorly diff, it's more like a carcinoma, so it's more high grade, less, it doesn't look like the neuroendocrine cells. Sometimes it's hard to have the testing working on those, so you have to make multiple testing to get the same characteristic results, yes. But we still have like some tools, but they don't look really the same, okay? And it's our high grade, so very, very atypical when you look at them. We'll have some pictures for you. And there's two types of the poorly diff. It's the small cells or the large cell. What does that mean? Small cells, the nuclei is very big and atypical, but there's very low cytoplasm in the cells. We'll review the cells as well, don't worry. And in the large cell, there's a lot of cytoplasm. So let's see. Okay, this is a cell. So, oh, I have a, oh yeah, okay. So, so this is the cell, this is the cell membrane. And then you see here, it's the nucleus, okay? So there's a lot of cytoplasm, usually because the neuroendocrine cells produce hormones, there's a lot of cytoplasm and granules in the cells, okay? So there's a lot of cytoplasm. So if it's a small cell, there's less, whoops, sorry. There's less cytoplasm, only the nuclei. If it's a large cell, there's a lot of cytoplasm, okay? This is a normal islet from the pancreas. So this is normal tissue. This is a normal pancreatic islet, so neuroendocrine cells, absolutely normal. So you can look at them, and then we'll go to the well diff. You'll be a good pathologist at the end. So this is the well diff, okay? Oh, I have my slides with the macroscopy. So this is the pancreas, okay, in yellow. Pancreas is lobulated. You can see the little small lobules. It's irregular, a little bit round. It's yellow. And then I don't know if you see here, it's white. So this is the lesion. Okay? The white lesion is the tumor. The yellow is the normal pancreas. This is normal, okay? This is normal, and this, do you see the round whitish? So this is actually a lymph node. This is a positive lymph node. This is a cancer, but in a lymph node, so a metastasis in the lymph node, okay? So now what we do in pathology, we actually take a sample of that and we look under the microscope. So we actually know what we're looking at. We take directly the lesion and we look under the microscope. Okay, so this is the lesion. Okay, so now here you have the normal islet. And do you see it looks similar? So here it's the lesion, this is well diff. You see it's very round. It's like bags of marbles. So the nuclei are round. The nuclei are blue, actually, okay? Very blue, so the blue round is the nuclei, and then all the pink is the cytoplasm, okay? And it looks a little bit like that. So this is well organized. It's regular. It seems like bags of marble. This is well differentiated. It looks a little bit like the normal tissue. Then if you go to the next slide, this is the poorly diff. Okay, and here you see it's like a little bit chaos. Okay, this is actually a small cell. All you see, it's blue nuclei, very dark blue, very irregular in shape, in size, and there's no organization, there's no structure. Okay, and if you look at the top here, you see this pink stuff. So it's actually necrosis, it's dead cells. When you see what we call necrosis or dead cells, it means that the tumor is growing so fast that all the blood and everything that can nourish the tumor, it's not enough. So some cells starting to really dying, okay? And all you see, it's actually ghost of cells. It's just the cytoplasm. The pink cytoplasm stay, and the nuclei just disappear. This is necrosis. When you see necrosis, it's usually with poorly diff tumors, okay, growing fast. And to the next slide, I have a large cell, okay, large carcinoma. There's a lot of pink cytoplasm. There's also blue nuclei, various shape, atypical, but also a lot of cytoplasm. Okay, so this is actually the subject of this talk. This is the classification. Don't worry, you'll be able to understand this. Okay, so first we have different system, and that's the goal. We want to unify the terminology. So the new classification, wherever you are, if it's in the lung, the gastrointestinal tract, the pancreas, we want the same terminology. So we have the well-diff neuroendocrine neoplasm, we have the poorly diff neuroendocrine neoplasm, and then we go in further details in the classification. So if it's a poorly diff, we already know about small cells and large cells, carcinoma. And here it's the next step of my presentation is it's more like if it's well differentiated, how can we grade and classify the well-diff tumors, okay? So we use the grade. What is the grade? So we know about the differentiation now, we don't know about the grade. So the grade is actually the biological aggressivity of the neoplasm, okay? So it could really look like normal cells, but it could still be aggressive. So how can we measure that? Okay, so we'll see that in a few seconds. I wanted just to point out that in general, if it's a low grade, it's less aggressive than a high grade, okay? It's very general. There is some heterogeneity within the same tumor. So within the same tumor, there are some spots that are low grade, some spots that are high grades, okay? And it can also vary in different sites. If we have a pancreatic tumor and a metastasis, it can be different, like a G1 and G2 grade. And also over time. So I'm a G1, and then I have a recurrence, and it's now a G2. That's all possible, okay? So we need to find the most accurate grade, so we need to calculate it. Okay, now I will show you what we do. So to calculate it, we have two ways to do that. We use what we call mitosis, and we use proliferation index. So first, mitosis. So a tumor to grow, the cells need to divide, okay? So a mother cell needs to give two daughter cells. And to divide, it needs to divide the DNA. So to do that, we use the process called mitosis during the cellular cycle. So a mitosis is actually the division of the cells into two cells, okay? So what we do is so here you see all the phases, the phases of the mitosis. So what we do is we try to find those images, those phases in the slides, okay? So like this. So here, so it's a bit of a detective thing. So we need to do, do you see? I'm gonna just, here, and there's one here, and there's one here, and there's another one somewhere here, okay? So you see them, you have to look for them, you have to know what you're looking for, and we do that in about 42 to 50 high power field under the microscope. So we need to scan the different field in the microscope to have a good count, okay? So that's when you see a score, a mitosis score, a mitotic index score into your pathology report, this is what we went through, okay? Then we have the proliferation index. What is that? So so first we need to do an immunohistochemical test in the lab. What is blue is negative, what is brown is positive. And what we see here is positive nuclei. So actually a nucleus that is that proliferates, it's actually brown, okay? So we'll see a bigger number, okay, if we do that, because the Ki67 range is a little bit more wider on the cellular cycle than the mitosis, but that's okay. This is for pathologists. But that's why sometimes the two count are different, because they don't count totally the exactly same thing on the cellular cycle, okay? But that's normal. So the way to do that is actually first to count all the cells we see, and then to count the positive cells and to do a division. So positive cells on total cells, and it's always in tumor cells, okay? We don't want to count vessels, and we don't want to count stromal cells and other cells, so tumor cells. We can do eyeballing, which is the method that mostly people use if it's really low, like 0. So you just scan the slides, there's no positive nuclei, then it's fine. It's a G1. If you see some positive nuclei like here, it's more difficult to just go and scan the slides and by just looking at the slides. You actually need to count them. So there's two ways to count. First, the manual count, which is actually to scan your slides, take pictures of what we call the hot spot, which is the most proliferative spot, print on a color printer, and actually take a pen and count a minimum of 500 cells. And then, like, you hope nobody comes into your office while you're counting, and nobody calls you for a result, because this is really like, it can, be really difficult, and you have to start over. So that happens, yeah. So now we're very lucky, because now at CHUM at least, and probably at Toronto as well, we have digitalized slides. All our slides are digitalized now. We work on computers all the time. And we can actually count with the software. So there's a manual count on the software that even if you're interrupted by anything, the count is still there, and you can see where your counts, and you can continue your count. Or also we validate an automatic counting, which is actually very, very nice. We run a software that we validate. It gives us the percentage on different hotspots, and then we can see where we are and be more accurate. There are some inaccuracies with the software. It's not AI, totally AI, but it's good. We can correct these inaccuracies, which is usually it counts twice a dot, so we have to, twice a nucleus, so we have to just redo the count really quickly. But then it gives you this. Okay, so this is the automatic counting. This is just one spot. We do 3 spots for each tumors. And the little blue dots are negative cells, and the red dots are positive cells. So here you see that there's 500 positive cells on 2,300 here. Oops, sorry. Total cells, and then it gives you a percentage of 21%. So this is a G3. And this is just to give you an idea. When it's a G1, you can see there's almost no positive nucleus. G2, it's in the middle, and G3, there's a lot. And this is a large carcinoma. It's almost 80%, very high grade, very high positive nuclei in a carcinoma, and also in small cell, that would be the same results. And so we reviewed the whole classification. So first, well diff, poorly diff. If it's poorly diff, is it small cell, no cytoplasm, or a large cell with a lot of cytoplasm? It's high grade by nature. Just by definition, a poorly diff is high grade. So the proliferation is very high, lots of nuclei. In well diff, you have to do your mitotic count. You have to do your proliferation index, hopefully with automatic counting. And then you can really see, you have in the last right column, you see the criteria of how many mitosis, how many, percentage of cells, and that gives you the right classification. And that's the best we have for now. It's the 2022 classification. So thank you. Thanks to the society, Dr. Mercier, and our dear PhD who count the cells for us. Thank you.
Good morning, everyone. My name is Marc-André Morin, and I'm a nuclear medicine physician here at the Montreal University Center, CHUM, not far away. And it is my pleasure to talk to you about biomedical imaging in nuclear medicine. The objective of my presentation is to make you understand the role of my specialty, nuclear medicine, in the diagnosis of NET tumors, and to familiarize yourself with the different treatment modalities that we can do in nuclear medicine and how we use those imaging techniques to plan the best course of treatment. First thing first, what is nuclear medicine? Most people don't know, so don't worry. Even some of my doctor's colleagues have no clue what we are doing in our department. So nuclear medicine, it is a medical specialty that uses radioactive substances to diagnose or to treat various conditions and disease, okay? We use very small amount of radiation that are called radiopharmaceutical, and we can inject them, inhale them, or swallow them to make some imaging or treatment. The radiopharmaceutical will release energy. They will emit gamma rays that are collected with specialized camera to make some imaging or to treat patient. The main difference with radiology, most people do know what radiology is, but nuclear medicine, the difference between the two is that in radiology, it is the camera that will shoot the radiation, the X-ray, towards the patient to give images, whereas in nuclear medicine, it is the patient that will release energy, that will emit gamma rays, that will be collected by the machine to make images. All right. So here's some of the toys that are used in radiology and nuclear medicine to make the imaging. First, we're all used to the back at it. There you go, to the radiology. On your left, it's all radiology equipment. So you have planar X-rays that you can do, radiograph, you're used to it. Then we can do 3D X-rays with the CT scan to see slice of your body, and you also have the MRI. All those modalities are very good for anatomical information, but not so much for functional information. If you want function, you need to go in nuclear medicine. We basically have two types of cameras. You have the SPECT CT, which is the top image right there. Okay, this is we can call it the old technology, but it's still very good. We have multiple radiopharmaceutical for this technology. For every single organ, we have an exam for that. Basically, you go within this little tunnel. You have two platforms that will rotate around the patient to collect the X-rays, to collect the gamma rays, to make 3D imaging of the nuclear medicine exam. Then you'll go within the gantry. It's a CT scan, low-dose CT scan, that we can correlate the images with the function of the organ. And on the bottom, you have the new kid on the block, the PET CT, which is the most sensitive exam. It's very good for function as well. You have higher spatial and energy resolution with this camera. So remember, two types of camera, two technology, the old one, the new one. Now let's talk about theranostic. It is a branch of nuclear medicine. It's a new word with the combination of therapy and diagnostic. The principle is quite simple. We use particular molecules that are very specific to a certain condition, to a certain cancer, and we can label these molecules with different radioactive substances to either do imaging or to do treatment. I will focus on the imaging part, and later on this morning, Dr. Plusnikov, my colleague, will talk to you about the therapeutic aspect of nuclear medicine, the famous PRRT. So the principle is quite simple. You treat what you see, and then you will see what you treat. You can actually see your treatment. It's a dream come true for oncologists. We spoke about this theranostics for the past 5 years, so people may think it's new, but actually we've been using this principle since the 60s with the iodine, radioactive iodine, to make treatment and diagnostic of thyroid cancer. And I'm using the homing missile analogy because it's very specific to our specific target. It targets only the cancer with minimal exposure to the rest of the organs, to the internal organs. And once again, theranostic. On the top, you have the radioactive sign. This is the radioactive substance we use. You can use either a therapeutic or imaging molecule. There's a linking molecule that will protect the binding molecule, which will target cells, specific cells in your cancer. So I also love the analogy of the key and the lock. Basically, at the surface of the cancer, there are some proteins called receptors, somatostatin receptor. You can see them as the lock, and we inject a radiopharmaceutical that you can see as the key. It will run through your body, within your vessel, the veins, the arteries, until they find the right lock, and they will bind to it. So that will bring the radiation closest to the cancer as possible, to either image the cancer or treat the cancer. And remember this slide because there's a post-test. I want you to draw the chemical molecule afterwards. So this is dotatate, okay? You have a little box. Let me show you right there. This is a little box. It's called a chelator. It's the DOTA part of the dotatate. This little box will enable us to fix the radioactive substances to the missile, if you want, okay? So you can either put some gallium-68 if you want to do some imaging, or you can switch for lutetium-177 if you want to do treatment. This little box will protect the rest of the molecule to make sure it goes to the right place and it finds the right receptor, the somatostatin receptor. Talking about receptors, you have different kind of them. You have 5 types of receptor. Depending on the cancer you have, it may change. You may have some amount of some and less than other one. The type 2 receptor is most frequent. It's a good thing because dotatate is really sensitive for this particular type of receptor. Now let's talk about pre-treatment imaging. You have SPECT-CT, remember the first old camera? Not that old, but then you have the new kid on the block, the PET-CT. The PET-CT is in the blue square, and you have the SPECT-CT camera on the A square. The SPECT-CT use indium-111 octreotide, and the PET-CT uses gallium-68 dotatate. You can see that the A image, the SPECT-CT image, is more blurry, once again, oldest technology, but I just want to reassure you that it can still be used to determine if you are eligible for PRRT treatment. In the NETTER-1 trial, the phase 3 trial that enabled Health Canada to accept the PRRT treatment, Octreoscan, SPECT-CT, old technology was used, so still good to use. The PET-CT, of course, probably the future, will have more sensitivity because of its higher spatial and energy resolution. So gallium dotatate PET imaging, you can see that all uptake is not only cancer. You have some physiological expression of somatostatin receptor in some of the organs. You have it in your pituitary gland, in the salivary gland, in the thyroid. You can see a lot of uptake in the liver and the spleen. This is normal, okay? It doesn't mean cancer. We use those 2 organs to score our cancer to determine if the patient is eligible or not for PRRT. You can see the kidney, you can see the bladder down there. This is because most of the excretion is renal, so it goes through the urine to get out of your body. So this technology is used for to search for well-defined, well-differentiated net tumor, for staging and restaging if there's a change in the symptoms, in the condition, and to see the treatment effects, you can follow it with gallium dotatate scan. So your physician may want to do a dotatate PET-CT, but you can also do an FDG PET-CT, which is basically radioactive sugar, because aggressive tumor will eat the sugar and will have more uptake on FDG than low-grade tumor. So when you have a grade 1, you should have a lot of expression of dotatate, so an high uptake on dotatate PET-CT, and minimal uptake on FGG. I'll show you some of the picture. And as more that you have more higher grade, the tumor might want to show more FDG uptake and less dotatate uptake. It is okay to have both uptake. We just don't want to find a tumor that has only FDG uptake and no somatostatin receptor, because those patients will not respond well for PRRT. Therefore, they won't be eligible for this kind of tumor. You may want to address it with other lines of treatment. Here's an example of a well-differentiated tumor. On the left, you have the radioactive sugar, which is FDG. You have no uptake at all. And on the right, you have the gallium-68 dotatate PET-CT, which shows multiple bone lesions. And when you take a look at the regular CT in radiology, you cannot see any disease at all. So this is an example of a well-differentiated tumor that would be eligible for PRRT. Once again, this is what we do every day. We look at scan with our PET-CT, and we can see that some uptake is not necessarily bad. You can have both uptake in FDG on your left and more uptake on dotatate. This means it's still a well-differentiated tumor. Now, let's take a look for what we don't want to find, dedifferentiation. That means that some of the tumor has no more somatostatin receptor. As you can see, the anterior part of the lymph node right there within the abdomen doesn't show any SSTR receptor, but it shows uptake with radioactive sugar, FDG. So you may want to address this lesion not with PRRT, but with a different line of treatment. This is the score we use. Remember, I told you that we were using the natural uptake of the liver and the spleen to classify our patient. Basically, we want an uptake that is higher than liver, which is Craning score 3, or higher than the spleen, which is Craning score 4. Both of these patients would be eligible for PRRT. If you have low score, it might be a good idea to do some FDG testing to make sure the tumor is not differentiated. Dedifferentiated, sorry. So that was for pre-treatment imaging. Now, per-treatment imaging, a very useful thing with lutetium-177 that Nicolas will talk to you about later on is that you can do some imaging of the treatment. So it does the therapeutic effect, but as well, it emits some radiation that we can uptake on the older technology, on the SPECT CT, not on the PET, but on the SPECT, to make imaging. This is useful because, as you can see on the left, you have the gallium-68 dotatate PET-CT. You can see the image are beautiful, clearer. You can see the uptake of all the bone lesions. And there's also the primary tumor within the abdomen and the lymph nodes. So we can do the staging, but then we do the treatment and we put the same patient under the camera right there, old technology camera, SPECT-CT, and we can make sure that the treatment is going to the right place. You can do dosimetry as well to make sure that you have enough radioactivity that is going to the cancer, and we can assess the response and see if the patient responds well or do not respond, if we need to change earlier the class of treatment. But don't worry, if you don't do per imaging technique for ourselves at CHUM, we don't do it for everyone. We only do it when we suspect that the disease is not progressing well, or when we start to treat and we have some borderline lesion with high FDG uptake and very low dotatate uptake. We may want to try the treatment and see if the patient responds. We may want to do imaging at the first treatment and the third treatment to make sure if we want to switch treatment, we can decide with this per-treatment imaging technique. This is an example of the SPECT-CT per treatment. This is lutetium this is actually the treatment that we can visualize. This is planar imaging. We can do 3D imaging as well with the CT. There you can see the uptake on the liver tumor. And this is what we do per treatment. And you can also do post-treatment imaging. You will use PET CT if possible, 3 months after the treatment to let the cell cycle go over and to see the maximum effect of the 4 cycle of PRRT. 3 months is the best way to image the patient. There you can see a very good response within the liver. You can see all the dark spots within the liver. That is disease. You can see that is shrinking on the 3-month post-PRT exam. And you can see as well that some of the bone lesion that you see in the thorax are completely disappearing. So you have a new baseline, and it's the reason why it might be a good idea to do some PET CT after your treatment to make sure where we start afterwards for the following course. So that was my presentation. Thank you all. If you have any question, I'll be there to answer them. Or if you're shy, you can come to my table to ask them. Thank you.
At this moment, I guess we'll take a 15-minute break, and we'll be back.